Sorry, previously I said you can read about the COX-2 inhibitors at the bottom of page 226, and they do mention those inflammatory agents, but it's actually on page 228. Can't see that far. So it's a table for common NSAIDs. And some of these NSAIDs are considered COX-1 inhibitors. They stop the cyclooxygenase at the beginning of its cycle. So these include aspirin and the common NSAIDs like ibuprofen, Toradol. And then the COX-2 inhibitors are a little bit more powerful. So once again, we're going to look at aspirin, acetaminophen, and the common NSAIDs. We've already talked about them pretty extensively in other chapters. We know that aspirin can also be called ASA. It stands for acetylsalicylic acid. Aspirin is a very good anti-inflammatory. It says it has great inflammatory action. It's actually anti-inflammatory action, and it limits the production of prostaglandins. So with aspirin, you're going to see pain relief, you're going to see inflammation relief, and you will see a decrease in fever. Acetaminophen is considered to be more appropriate for mild pain that would give you maybe up to a 4 on the pain scale. It's relatively safe when taken as directed. I think the common limit used to be 4 grams a day or 4,000 milligrams. I think they have lowered it to 2,800 milligrams a day or 2.8 grams. After that, somebody needs to seek help from their doctor if they have to take more than that. Remember that acetaminophen works at the level of the brain and helps with pain perception. So it's not an anti-inflammatory. It doesn't necessarily work at the site of the pain. And it's going to work on the hypothalamic control of the body temperature and cause vasodilation and sweating. But it's not considered to be an anti-inflammatory. And then we have the NSAIDs, ibuprofen, and those similar drugs, also for pain, also for inflammation. And it also is thought to limit the production of prostaglandins. So it's going to decrease inflammation at the site of the pain and discomfort. So when we talk about management of inflammation in the body, we will talk about the use of aspirin and NSAIDs, non-steroidal anti-inflammatory drugs. We will talk a little bit about the corticosteroids, again, in use for these particular conditions. What we call DMARDs, or disease-modifying anti-rheumatic drugs that actually work on decreasing the inflammatory response itself, and then drugs that are considered to be anti-gout medications. We know that anti-inflammatory drugs are given to reduce pain and limit those blood vessel responses to any joint injury, because it's repeated blood vessel responses with all the chemicals that respond that eventually are going to cause that permanent damage to the bones and the joints. All right, so let's talk about the anti-inflammatory drugs. So looking at table 12.1 on page 228, we've got the COX-1 inhibitors. Aspirin and ibuprofen would be our prototype drugs. Nobody's really sure exactly how these drugs work. It's a little bit unknown, but they're pretty sure that it blocks the action of prostaglandins, those tissue hormones that help mediate in inflammatory responses. They act as analgesics, so they decrease pain. They decrease inflammation at the site, and they will work to decrease fever. We use them for rheumatic diseases, so diseases of the bones, joints, and muscles. Degenerative joint disease, where the joints just start to give out from repeated use. Osteoarthritis, which usually affects maybe one side of the body, a joint here and a joint there. And then acute musculoskeletal problems like sports injuries. The most common adverse reactions to NSAIDs and aspirin are GI problems. They're hard on the stomach. And anyone with an allergy to aspirin can also be cross-sensitized. They can have an allergy to other NSAIDs as well because chemically they're somewhat similar. Remember that allergy to aspirin can be common because it has a natural origin, and so the body sometimes does not react well to aspirin. And you get the common hives, rash, itching, difficulty breathing. These drugs, the NSAIDs, the COX-1 inhibitors, don't mix well with alcohol because of irritation of the GI tract, and they don't mix well with other NSAIDs. That can cause a lot of GI irritability and a tendency not to clot as much. And if you mix them with anticoagulants, such as Coumadin, they don't mix very well and can cause increased bleeding risk. NSAIDs can cause kidney damage. If you take too much ibuprofen or a similar NSAID, eventually the kidneys have trouble because they have to excrete all that medication. So you just need to follow the physician's orders. If a person is prescribed high-dose NSAIDs, they need to take on a regular level to keep an even amount in their bloodstream, but then remember that that high level can cause kidney damage, and usually a responsible healthcare provider is going to do periodic BUN and creatinine to see how the kidneys are taking it, I guess. Stop drugs before surgical procedures. Usually they'll say 2 weeks before because of increased bleeding risk. And as before, we said do not take in the event of liver disease, a TIA, or symptoms of a stroke, because while an ischemic stroke, there probably would not be any problems. A hemorrhagic stroke, where you have uncontrolled bleeding in an area, aspirin and NSAIDs are only going to make that worse.